Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. Thank you for joining us today. You're among 2,200 clinicians who registered for this popular webinar. Our educational session is entitled Ultrasound-Powered Aesthetics, Precise Masseter and DAO Botulinum Injections and Perioral Filler Placement. Ultrasound has proven to be an invaluable tool in improving the safety of facial fillers to avoid complications like vascular occlusions and deliver predictable results. But what about Botox? Masseter treatment can inadvertently cause paradoxical doubling up or bulging unless an equal amount of botulinum is injected in the intermediate, superficial, and deep heads of the masseter muscles. In a moment, we'll be joined by cosmetic physician, phlebologist, and ultrasound expert, Dr. Stefania Roberts, who will teach us ultrasound techniques for safe masseter, depressor anguli oris, and perioral injections to achieve the desired aesthetic outcomes. She'll demonstrate handheld ultrasound techniques from vascular mapping to muscle identification to needle visualization, all of which can help make our injections safe, accurate, and effective while avoiding complications. Before we get started, just a quick housekeeping note, please do feel free to use the questions box at any time during today's webinar, as there will be a live Q&A session following the presentation and live scanning. It's now my pleasure to introduce you to Shelley Gunther, your host for today's event. Shelley is an experienced sonographer with over 25 years of experience as a clinical ultrasound expert. As clinical manager at Clarius, Shelley is dedicated to providing the highest quality educational content for clinicians looking to add wireless ultrasound to their practice. She helps us deliver practical webinars like today's event and video tutorials for our Clarius classroom, which now features over 200 on-demand video tutorials. Hi, Shelley, and over to you.
Thanks, Jeunesse. I always giggle a little bit when you say ultrasound expert because I feel like nobody is an expert, and I've been doing this for so many years, and I'm still learning all the time. Welcome, everyone, to our first webinar with Dr. Stefania Roberts, joining us all the way from Melbourne, Australia. I am pretty sure she's there today. She, between her practice and educating the masses, this lady is very busy, has a very busy travel schedule. So this is going to be great. So today's topic touches on a couple of things in the aesthetic world, botulinum injections as well as filler injections, and how to make them both safer and more effective. And just before we get started, I'd like to just present a couple of papers that are out there in the literature. And this first one is a brand new article from the Aesthetic Surgery Journal, aimed at describing the basic principles for filler and biostimulators with the assistance of high-frequency ultrasound, and in particular, color or power Doppler. The techniques were both scanning before the injections and during the injections. And the authors summarize the steps involved when folks are just getting started using ultrasound to guide aesthetic procedures. And it's a great article that covers everything from equipment choice to practical issues related to the various procedures. So I would encourage everybody to have a look at that. The next review article talks about how botulinum injection is the most commonly performed procedure in cosmetic surgery, but variation in patient anatomy is the main contributing factor to complications, again, indicating that ultrasound can be a really useful tool for a variety of facial injections. And finally, the purpose of this study was to identify safer and more effective botulinum neurotoxin injection points and strategies using ultrasonography to determine the structural patterns of the deep inferior tendon with the aim of reducing masseter muscle injection side effects. And just before we get started, I'd like to put a little poll out to the viewers today, just to ask, what key benefits do you see ultrasound bringing to facial aesthetics? Is it something that you think is just going to increase your referrals? Increase your patient's confidence? Are you looking to be able to better identify anatomy? I'll just give you a couple of seconds here just to close out the poll. 3, 2, 1. Great. So kind of across the board, but yeah, mostly looking for vascular structures and reducing complications involved with injecting into vessels. So I think you'll find this really good today. So let's get this show on the road. I'm very pleased to welcome Dr. Stefania Roberts to share her knowledge and experience on the topic of ultrasound-powered aesthetics. And as we'll see, Dr. Roberts uses ultrasound for a variety of applications. Now, as well as performing sclerotherapy, EVLT, and laser vein treatments in her practice, she's on a number of advisory committees for cosmetic uses of muscle relaxant injections and dermal fillers. And it's these treatments she predominantly performs at the Dermatology Institute of Victoria. Dr. Roberts has trained other doctors in the use of various cosmetic injectable products in both Australia and on an international platform in a number of Asian countries since 2002. So without further ado, I'll hand it over to you, Dr. Roberts.
Thank you so much, Shelley. Can you hear me loud and clear?
Absolutely, yes.
Even though I'm down under, got to put a bit of my personality into this one, Shelley. Thank you very much for this beautiful introduction, and I'm very excited to be part of this Clarius webinar. And, you know, you're a sonographer that's been doing this for 25 years. I've been a phlebotomist and an aesthetic physician for the past 26 years, and I'm still learning. And I think ultrasound has just opened up a brand new world for me. I've been using it in aesthetics for at least the last 15 years. But in the last 5 years, my knowledge has skyrocketed, and I am still learning and trying to perfect my technique. So what I'd like to do with my presentation is make this a very practical presentation where I'm incorporating what we as clinicians see in our day-to-day aesthetic practice, and where we can utilize ultrasound and how it can be used as a useful tool to identify anatomy. I'm glad that that poll came out to look at the vessels, because we'll be covering that. And more importantly, how to troubleshoot complications so that you can resolve an undesired clinical outcome. So to that end, what I'd like to do is to showcase ultrasound in a number of clinical scenarios via a number of different clinical case studies. And I'd like to look at the injection of botulinum toxin to masseters, then going across to the depressor annuli oris, DAO, with Botox. And then I'm going to shift the attention to perioral filler placement, focusing on the superior and inferior labial artery. And then one of my key areas that we're going to demonstrate in our little demo after the presentation is on ultrasound. How do we identify and how can we be sure that what we're looking at on ultrasound is an artery or a vein? And we're going to be utilizing B mode ultrasound. We're going to be looking at color. And then more importantly, we're going to be placing a spectral trace on the vessel so that we can be sure that what we're looking at is either an artery or vein, which is super important when we're injecting out high-risk areas, for example, the temporal fossa, the piriform recess, so that we can avert any complications. So again, this is the way I'll be doing the presentation. The first case study is to look at masseters. So the first patient that I will be exhibiting here is a patient who's 27 years old. She's a grinder, a clencher. The reason we treat masseters with a neurotoxin is either because the patient is a therapeutic patient that is clenching, grinding, or for facial reshaping. And when we're looking at the masseter, we are all familiar with the anatomy. And I thank Waffles Wu from Singapore for lending me this beautiful anatomical illustration where we can actually see the three heads of masseter. And as Janesse said, there are three. There's the deep head that we can see here in yellow, the intermediate head, and the superficial head. And all three originate from the zygomatic arch. The deep head is a little bit more posterior. It runs vertically down to insert into the ramus. It is overlaid by the intermediate head that is originating slightly more anterior on the zygomatic arch, runs vertically down again to insert into the ramus. And then we have the superficial head, which is a little bit more anterior to the other two, runs in an inferior lateral direction at around about 45 degrees, and again to insert onto the ramus. And when the patient clenches, we see this bulging in the lower third of the face, and this is what we're addressing with our neurotoxin. But let me just translate this into what we tend to see on our ultrasound image so that when I showcase the video of the patient, you'll be able to identify the three heads. But before I do that, this is what I tend to explain in training sessions. If you place 2 fingers, and if I place them on my masseters, what you'll find is that if I put 2 fingers at the bottom and overlay my third one, the finger that is more medial is the intermediate head of masseter. The one that is more posterior is the deep head, and lying superficial to the two is the superficial head of masseter. So medially, the intermediate head, posteriorly is the deep head, and lying superficial to the two is the superficial head of masseter. So let's have a look at this image, because when we have a look at this image, you can see from the pictogram in the bottom left-hand side that the probe is held in a transverse position. We can identify bone being hyperechoic, it is bright white, and we can then see superficial to the masseter subcutaneous tissue. But here, that in delineated in the same colors as Waffles Wu's presentation, what we have is on a more posterior and position, the deep head of the masseter. Lying more anterior and deep is the intermediate head of the masseter, and lying superficial to these two heads is the superficial head of masseter. So let's dive into our first case and see how I injected this patient with Botox to reduce her clenching and grinding.
Marking the left masseter, again, can I ask you to clench? Anterior border of the masseter, along the mandible, the ramus, and again, a line from oral commissure to tragus, and the injection points will be in the lower half of a line that divides these. Can I please ask you to clench? Relax, clench, relax, clench, relax, clench. Great. Now we can see that the right masseter is larger compared to the left masseter. I'll be injecting the right side with 40 units of onabotulinum toxin, and on the left hand side 35 units of onabotulinum toxin, and my approach will be from posterior, single entry, dividing the doses, 35 units divided by 3 in each of the bellies, and then 40 units divided by 3 in each of the bellies on the right hand side. The only muscle that I'm concerned about is the risorius, because if I inadvertently strike the risorius, I will shorten the patient's smile, and injecting each of the 3 bellies of masseters avoids the inadvertent paradoxical doubling up of masseters if I don't equally distribute the botulinum toxin in each of the 3 bellies. Let's have a look at the masseters on ultrasound. Let's have a look at the left masseter. I have the probe in the transverse position. I'm looking at the 3 points that I've marked, and I can locate the intermediate belly of the masseter. Going more posteriorly, I have the deep head of masseter, and then more superficially, I have the superficial head of masseter. Could I please ask you to clench? And we can see that bulging out. Relax and clench. Great. So I will be equally distributing the botulinum toxin in each of these 3 bellies that are easily visible on the screen at the moment. But let me have a look at risorius, and here is the masseter, and coming off the masseter, aiming in a more anterior position, lying around about 0.6 millimeters deep to the skin is a thin layer of muscle, and that is risorius. Ultrasound, we can identify the intermediate head of masseter, the superficial head, and the deep head. And I want to do 1 injection point so that I can target all 3 muscles. So little sting coming your way. Ready 1, ready 2. And I'm now locating my needle on ultrasound. I can see the movement. And there I have it. and this is the intermediate head. So I'll inject a third the dose into the intermediate head. I'm now going to move my needle and reposition it so that I can target the superficial head of Masseter, and another 1/3 of the dose. And then I'm moving my needle again to target the deep head of Masseter. Let me see if I can locate my needle. I can see the movement. And there it is. And here is my third dose of onabotulinum toxin. I'd like to visualize where the onabotulinum toxin is. This is immediately post-injection, and we can see volume within the intermediate head, the superficial head, and the deep head of Masseter.
Okay, so why did I do a single entry point in this patient? I came from a posterior approach. I did it single-handedly, and I went posteriorly so that I could approach all three bellies and avoid inadvertent injection of risorius, which lies more anteriorly. So let's have a look at what I achieved with this patient. We can see in the before images with the patient, again, the pictogram in the bottom left showcases that I'm looking at the masseter in a transverse position. The relaxed state shows that the vertical height of the masseter is 10.1 millimeters. And when the patient with the image on the right-hand side contracts her masseter, the vertical height is 16.1 millimeters. So if we then have a look, 3 weeks post-injection of 40 units of Botox to the patient's right masseter, 35 units to the left masseter, the result is as such. We can see that on the left-hand side, at rest, I could have got it slightly from a different position, but it is essentially the same, maybe a little bit shorter in its vertical height. But more importantly, when the patient contracts, we can see that it has decreased from 16.1 millimeters down to 9.56. So we've got a quantitative measurement of the change that we've achieved with this patient with ultrasound. So it's a great research tool. But let's see how this correlates with our clinical picture. So if we have a look at our patient pre-Botox, we can see that she's quite square, she's quite boxy. Again, her treatment was executed because she's a grinder, she's a clencher, and we can see the ovalization of her face 3 weeks post, the 40 units on the right, 35 units on the left. And if you look at the correlation with the ultrasound images pre and post, the striking result is shown when the patient contracts pre to when the patient contracts post, which correlates with what we are seeing clinically. So great little tool to inject the masseters. So it's quite kind of useful to do this single posterior approach to avoid risorius. But one of the other complications that can occur when injecting masseters is, for example, in this case, which is one of my patients who presented to me around about 15 years ago. And again, she's a little bit on the boxy side, on the lower third of her face. We consider a female to be more attractive if they're a little bit more oval. And in this patient, she was a little bit concerned about having any neurotoxin to reshape the face. So I dropped my dose significantly. And what I did with this patient is I did a single injection point, and I injected her with 10 units on her right-hand side, 5 units on her left. And 24 hours later, she sent me a text and she sent me this image. And she said, Dr. Roberts, every time I'm eating I'm bulging and I look like a fish. And she's got that, you know, the Popeye kind of look. And it's not very attractive. And every time she's eating, this is what's happening. So this was my very first case. So of course I contacted all of my mates, got in contact with the plastics, with the derms, and said, what have I done? And, you know, I researched the literature. And back then, in 2006, Stephen Liu published a paper that basically said that, in his opinion, when we see this paradoxical doubling up, that it's potentially due to the fact that we've struck a vessel and we've got a hematoma. Now, I'm good, but I'm not that good that I'm going to get a hematoma bilaterally in one treatment. So my curiosity took the better of me, brought this patient across to the vein clinic, and together with my sonographers, we had a look at what was going on. And what we found was this. If we look at this image just quickly, because back then, if we look, this is again a transverse look at the masseter. Medial is the intermediate head of the masseter. Lateral, we have the deep head of masseter, and lying superficial to the two is the superficial head of masseter. And when this patient contracted, this is what we found. The superficial head, when I was asking the patient to contract and clench and palpate her masseters, what I found is that the masseters, they were soft, and I couldn't work out what was going on until I put the ultrasound onto her. So when the patient contracts, what we can see is that the intermediate head and the deep head of the masseter, when they contracted, they basically enabled the superficial head to herniate up. And when I was palpating her masseters, that was what I was feeling, because they were soft. So the way that I troubleshot this patient to resolve the issue is under ultrasound control, remembering my dose was a single dose. First error. Second error was that I underdosed the patient because she was concerned about too much facial slimming. So what I did in this case is I injected the intermediate head under ultrasound control with 5 units of Botox, and the deep head with 5 units of Botox under ultrasound control. And within 24 hours, that paradoxical doubling up had settled in this case. It doesn't always happen in 24 hours. I recently had a case, again bilateral, not mine this time, and it took around about 3-4 days before that paradoxical doubling up from ultrasound guided botulinum toxin injection resolved the issue. So in this case, this is where ultrasound can help us troubleshoot a problem and understand what is actually going on. So this was our masseter case. We're now going to move on and go to our next case, where I'm moving on again, focusing on musculature, looking at injection with botulinum toxin. And we're going to now move across to the depressor anguli oris. Now, the depressor anguli oris, like masseter, like temporalis on ultrasound, are very easily identifiable. So these are really good muscles to learn on when you're first using ultrasound. So thank you to Peter Cullen and Stephen Liu, two plastic surgeons here in Australia that run many cadaver workshops. They've lent me this beautiful image of a cadaver where you can clearly identify the depressor anguli oris. It's also known as triangularis. It originates from the oblique line of the mandible, and it runs superiorly to insert into the modiolus, and it is a powerful depressor of the lower third of the face, and an area that we typically inject with neurotoxin. Note the position of the depressor labii inferioris, lying immediately deep to the DAO. And as Peter Cullen and Stephen Liu have alluded to, if you look at the pars labialis of the platysma, the DLI appears to be a continuation of the pars labialis of the platysma. But of note here, so that we can correlate this to our ultrasound image, the DAO, we all know, lies superficial to the DLI, the depressor labii inferioris. Why is that important? Because again, when using neurotoxin, we can inadvertently hit the DLI either from injection with neurotoxin to the DAO or the mentalis, and we can inadvertently strike the DLI and end up with a skewered smile. So let's have a look at what these structures look like on ultrasound. So if we have a look at the pictogram, my probe is in a longitudinal direction and going from superficial to deep. We have subcutaneous tissue and the very easily discernible depressor anguli oris, and then we have the mandible. So this is a longitudinal image of the DAO. So let's have a look at a case. This patient is contracting her DAO and the probe is held in a longitudinal fashion. We're looking at the left DAO and we can see it relax, and then when the patient contracts, we can see the DAO contracted. So this is the patient's left-hand side. When we're looking at the patient's right-hand side, again, the probe is in a longitudinal orientation, and we can see it relaxed. And again, when it's contracted, it increases in size. So in this particular patient, what I did is I injected her depressor anguli oris. And what I did is injected her with 2.5 units per side. On the patient's right-hand side, I decided to inject with a 25 gauge 30 millimeter long needle in a short axis, and her left-hand side, I'm injecting here in the longitudinal axis and delivering 2.5 units per side. Now, do I use the ultrasound for all my DAO injections? The answer is no, but I do use it when I end up with complications. So if we have a look on ultrasound, what the DLI looks like, it's a small little slither. It is not easily identifiable. This is my face, and we can identify here the depressor anguli oris. It's quite a robust muscle, but lying deep to it and in a more medial direction, we can identify the depressor labii inferioris, and lying deep to it is the incisivus labii inferioris. So at least we can see that the DAO, if we look at our scale on the right-hand side, it's lying quite superficially. So when I normally and typically inject the DAO, I usually point my needle laterally. It's usually an intradermal injection so that I can target the DAO and avoid injecting the DLI, which lies in a deeper plane. So why do I do that? Because this young lady, I injected her full face Botox. She looked incredible until I got this result by inadvertently injecting her left DLI, so that in this case, you can see the downward pull on her right-hand side. And in this case, that's her normal side. And to resolve this issue, what I did do in that case, because I wasn't using ultrasound at that point in time, I injected around about half a unit of Botox towards the origin of the DLI to resolve this issue. This is a patient from many years ago. But in this patient, she actually, when I reviewed her a few years later, she was pulling more with her DLI just naturally on her right-hand side. I exacerbated the problem when I inadvertently struck her left DLI. And these days with this patient, I've injected her DAO with ultrasound to avoid this problem happening again. So again, we can utilize ultrasound to clearly identify our musculature and use it when we've had a complication or to resolve a complication, because I could have used my ultrasound in this case, but this was a number of years ago, to inject the DLI under ultrasound control. So from injecting musculature, what I'd like to do now is to move across and look at our third and fourth case studies that I'd like to share with you, looking at orbicularis oris, but in particular, focusing on vasculature and looking at the superior and inferior labial arteries. And the paper you're all familiar with by Cotofana that was published back in 2017 in PRS clearly showed that when we're looking at the superior and inferior labial artery, in 78% of cases, it was submucosal. In around about 17%, it was intramuscular. And rarely is it found in the subcutaneous space. And that's where we tend to inject with lip filler. And this paper was followed up by a revised version using ultrasound to delineate the anatomy of the upper and lower lip. And there are two key points that I want to make about this paper that are relevant to us in clinical practice. One, if you look at figure 9, you can see the diameter of the superior and the inferior labial arteries. They're huge tubes, huge. I'm surprised that we don't have more VOs, vascular occlusions, because these vessels are massive. When we look at figure 6, we can see that in this revised version, that what the team Cotofana found is that when we're looking at the red lip in the central upper lip and lower lip, in 100% of cases in their paper, they found that the superior and inferior labial artery were found within the red lip. But as we went into the lateral third of the lip, in around about a quarter of cases, it was found in the cutaneous lip and the remainder of the time in the red lip. But anatomy never follows any of the papers that have been published. And this is where ultrasound comes in very handy so that we can actually look at the anatomy of our patient at hand. So let's have a look with ultrasound firstly, what the upper lip looks like on B mode. So again, the probe is held in a transverse direction. We can clearly identify subcutaneous tissue, and it is hyperechoic. We can see orbicularis oris, and orbicularis oris, like many muscles, is hypoechoic because of the vasculature. And we can identify this circular structure that's anechoic. It's black on B mode. And the question is this filler? Is this a vessel? And the only way that you can identify whether it is either of those is to put your color box on. And in this case, it was the superior labial artery. So let's have a look when we put color on. And if we look at the superior labial artery, when we're looking at the superior labial artery as it enters the upper lip, we can see that it lies superficial to the orbicularis oris. But as we proceed in a more medial direction, this snake is actually traversing from this subcutaneous plane. It's going through orbicularis oris to come back up to the subcutaneous plane. It's in all three planes. And in this case, we can clearly see the columellar artery. Look at the robustness of the size of this vessel. So that's the superior labial artery. When we look at the lower lip has similar anatomy. And when we have a look here, we can see one hyperechoic domes, and these are the teeth, the gel in the near field of my B mode image, subcutaneous tissue, orbicularis oris, and that's in the lower lip. So I placed these pictures here so that you become a little bit more familiar for those of you who aren't using ultrasound yet, so that when you have a look at my two case studies, you can identify these structures, because we all know with ultrasound, it is all about pattern recognition, and repetition is key. So get a probe in your hand and start playing. So let's start with case number 1.
Perioral rhytids. We can see some fine lines in the upper lip and in the lower lip, white cutaneous lip. I'd like to address these areas with some Volite using a 25 gauge cannula. Before injecting, the vessels that I'm concerned about are the superior labial artery and inferior labial artery. So before injecting, let's look with ultrasound what we can identify.
So what we can see here in the upper lip, you can see the B mode image and quite a large superior labial artery that right now is lying deep to the orbicularis oris. And as we proceed in a more medial direction, it is still deep to the orbicularis oris, but it's starting to proceed a little bit more superficial as we went medially. We can identify the teeth, and going to the lower lip as well, we can see orbicularis oris. It is a hypoechoic structure. And when we have a look, we're now in the cutaneous lower lip. We can identify our vessel in the near field, and it's quite a tortuous vessel, the inferior labial artery. So here I've got a 25 gauge cannula. I chose Volite. I wasn't trying to create volume. I'm trying to address lines. I'm injecting in a platform technique and placing the product, hopefully superficial, to the orbicularis oris. And when I have a look post-treatment, we can actually see the HA found superficial to the orbicularis oris, and we can see that the superior labial artery has not been tampered with, and the product is indeed found superficial to the muscle. That's in the upper lip, vessels nice, intact, and showcasing that I haven't caused any issues. And the product is found in the near field. Again, when we're looking in the lower lip, we can identify orbicularis oris, the hypoechoic structure, and we can see the vessels quite clearly as well. So that is utilizing ultrasound for the upper and lower lip, but let's just relook at a second case where I utilize needle into the red vermilion and showcase the anatomy of both vessels before injection.
Upper lip, and we can see the superior labial artery, and in the lower lip, quite a bit of activity with the vessels. And again, on the patient's right hand side, the superior labial artery, always a large tube, tortuous, running in and out of orbicularis oris. And in the lower lip, we can see the vessel deep to orbicularis oris. Okay, now that I know the anatomy, let's inject.
So you can see here, I'm injecting superficial to the orbicularis oris. I've got tiny amounts of filler and injecting tiny amounts just to rehydrate this patient's lips. I delineated the anatomy. And when you place ultrasound on a patient, you kind of almost think, I'm not injecting you with filler today. Let's go to neurotoxin because there's a vessel everywhere. So that was the case, and excuse the typo with the orbicularis. There should have been an R after the O for orbicularis. So that is the injection in the perioral region. Now, what I'd like to do here is to actually focus a little bit on how do we identify and distinguish an artery from a vein using ultrasound. And I actually think that this is one of the areas that I like using ultrasound probably the most, because I want to avoid in my high risk areas inadvertently getting into a vessel. And in fact, in this day and age, I won't inject the temporal fossa without ultrasound, and I do inject under ultrasound control. So in this image, what we can see quite clearly is that I've got the B mode image, the brightness mode image with color overlaid on top of the B mode, identifying a red and a blue structure. Now we can see on the left-hand side of this image what we call a color scale. And on top of this color scale, there's a red, we can see the red color, and on the bottom is a blue color. So number one, anything that is red with color is not an artery, and what is blue is not a vein. It's the color scale is to demonstrate when we're using color Doppler, the direction of blood flow. Key take-home message here is whichever color is on the top of your color scale, so always look at it, whatever the color is, means that the blood is moving towards the transducer. Whichever color is on the bottom of the scale means that the blood flow is moving away from the transducer. So the acronym that many of you would have seen that says BART, B-A-R-T, which is blue away, red towards, is correct with this color scale that we've got here, but I can invert that color scale and put blue on the top, and red on the bottom, and Bart becomes useless. So I have a color box that I've placed onto this vessel. I have periosteum, and let's have a look at what we're looking at. In this case, it is actually an artery that's red and the vein is actually blue. But in our demonstration, Shelley is going to beautifully demonstrate in B mode the difference between an artery and a vein. And a vein on ultrasound is collapsible. It is compressible. It will blink at you. Arteries are non-compressible. Now, that's the case with arteries in most parts of the body where the vessels are larger diameter. For example, the carotid. And if you get your probe and look at your carotid artery, you're not going to be able to compress it, but you'll be able to compress your internal and external jugular veins because they're huge tubes. You need to remember that in the face, we're talking about small caliber vessels. They're going to be anywhere between 1 to 2 millimeters, maybe a little bit bigger, but typically your arteries are 1 to 2 millimeters. Your veins are slightly bigger. So on B mode, the difference between an artery and a vein is collapsible. An artery may also be collapsible because remember, when we're looking at the line of ligaments, anything in the anterior face involves muscles of facial expression. And one of the reasons that the arteries are so tortuous is that they don't get crushed every single time that we're allocuting, we're talking. So they're tortuous and they're slightly compressible. So that compressibility is not always an indication of whether it's an artery or vein. On B mode, sometimes you can actually see that the artery is pulsatile. So look for it. More's missed in medicine by not looking than by not knowing. So see if on B mode you can see pulsatility. But when we place color box on, what we can see here is that the artery, you can see with color, it is red and it is pulsating, and the blue structure to the right of it is indeed a vein. But to be 100% sure that I've actually got an artery, what I've actually done is I've actually dropped a spectral trace within the lumen of the artery, which is quite difficult to do because these vessels are quite small. But what I've done is I've placed the gate within the center of the lumen of this artery, and I'm looking at the angular artery. The probe is in a longitudinal direction, and this is a classic arterial waveform. So if you ask any sonographer, the more definitive way of distinguishing an artery versus a vein is to actually get a spectral trace and look at the waveform. This is a biphasic waveform that we can see. You heard the pulsations of the angular artery. An arterial waveform can be biphasic or triphasic, and this is a spectral trace associated with an artery. What does a vein look like? So let's have a look. A vein, even with color, is quite sluggish. You see an artery, it's pounding, it's just pulsating, and on the bottom left-hand side, you can see it, but look at the difference in caliber. The artery is much smaller, it is pulsatile, it's not in my field because I'm focusing on the vein, and lying just lateral to that vein, there's also an artery. But let's interrogate these two vessels to see what they are. So the vessel more lateral is indeed an artery. We've got that beautiful biphasic nature to the arterial waveform. But when I put the spectral trace on the vein, it is a monophasic waveform. This is a typical venous waveform, and it varies with respiration. And again, here with color, we can see the pulsations of the angular artery clearly discernible, even with the color Doppler on. But the spectral trace, as you've just seen before, is a more definitive way, especially in the face where the vessels are small, to distinguish an artery from a vein. So on that note, I think I'm kaputskis with my presentation, and I think we're going to now move on to a live demonstration.
Yes, I have a model here, and I'm just going to run over to her and start scanning. It'll be a kind of a brief demo. I want to remind everybody to enter your questions using the Q&A at the bottom of the screen, and we will do our best to get to all of those questions before the end of the webinar. And if we have lots of questions, we may go over about 5 or 10 minutes. So Just going to head over here. And the first thing I want to just draw your attention to is the different presets here. And we have tons of newish presets for aesthetics. And these presets are going to get you closer to where you want to be with your imaging parameters. So I'm going to select cheek here, and we'll just put the scanner down. And another thing I want to demonstrate to you is our new feature called voice controls. So I'm going to turn on the voice controls, and this way I can make imaging adjustments without touching the screen. I'm just going to feel the mandible and put my scanner down over the masseter muscle. And I'm going to tell the Clarius app to increase gain, increase depth. Right. All right, so Dr. Roberts, what am I seeing here?
You're seeing the mass. I love the voice control. This is absolutely brilliant.
I know.
When you're doing
it is.
It's a great new addition to the armamentarium, because you don't have to touch the screen and you can keep yourself as clean and as sterile, or sort of sterile as you can be. So I love voice control. So here we can see the masseter. And this is great because you're in Canada, I'm in Australia, and you're my hands. Love it. So this is good though, because it'll be great, because I'm going to actually try, and if I talk through what I normally see, it's a great learning curve for the people that are actually on listening. What I like to do, and again, B mode is always needs to be optimized before we put color or spectral trace on. And for me, what I like to do is I actually like to, in this case, just maybe decrease the depth by a smidge, maybe bring it to 2.6. So that we're focusing our key, 2.3, perfect. You're a sonographer, Shelley. So you're optimizing your B mode image. And again, this is going to be variable depending on your vision and my vision. When I'm doing endovenous procedures, I have to adjust my vision with my sonographers. I like to decrease the gain in the far field. So if I decrease the gain slightly in the far field, I like to keep my image bright in the near and midfield. So I think that is great. Do you want to just demonstrate the three heads of the masseter in this patient?
So if I move a little more laterally, kind of posterior, we're seeing the deep head, which is here, and they're actually seeing the parotid gland here as well, right next to it.
Nice homogeneous structure. So just because of where your hand is, when you're insonating and looking for the masseters, have you placed your probe in trans? And then I tend to put my finger on the mandible, place the probe in trans, and then locate. I always try and orientate myself and do exactly what you've done, Shelley. Run posteriorly to identify the parotid gland, a homogeneous structure. And unfortunately, sometimes filler can inadvertently be injected into the parotid gland. And I think 2 weeks ago, I used ultrasound guided highlights to remove the HA from the parotid. So we can identify the parotid, and then running still in transverse, but more anteriorly, we can then see the deep head of the masseter. Nice. And then more anterior to the deep head, we have the intermediate head of the masseter. A little bit further inferior, that one, yes, there. So the intermediate head. And if we lose our orientation, if we ask the patient to clench.
Can you clench, please?
And relax.
And clench. And relax. Great.
And we can identify, if you go a little bit more anterior, we'll be able to identify a little bit more anterior, that's it. And clench.
Clench. Great. Relax.
There it is. So it's actually found superior. It's more, that's the intermediate head. And then just lying superficial to it is the superficial head of masseter. So if you stay there, Shelley, go back a bit more anterior. Oh, isn't it terrible when I don't have control of my probe? So if you go a little bit more anterior and clench, if we ask the patient to clench.
Okay.
And there's the superficial head of the masseter.
Okay.
Gotcha. So yes, Yes.
Okay.
Very important. So you've identified the 3 heads. Now, not easy to identify, but important from an injectable point of view, because I've had every complication with Botox. I've been injecting 26 years. The one I haven't had yet, and it will probably happen today when I start practicing, is I haven't inadvertently struck risorius yet. But risorius is a very, very thin muscle, and not everybody's got it, but there it is. Beautiful. So you're finding risorius. It's a little slither. It's found superficial to the masseter, and it runs anteriorly to insert into the modiolus. So you're now at the anterior border of the masseter.
Right here.
Yep. And if you take your little yellow circle up, you'll be able to see the tiny slither with the eye of faith is right up there.
So just in the essence of time here, I'm just going to show what you were talking about, the blinking vein here. So I'm seeing a little vessel here. And if I put just a little bit of compression, I can make that disappear. And so we know that that's a vein. We're fairly confident that that's a vein by just a little bit of compression.
Yes.
And then I can go in and just turn the color Doppler on here. Okay, and we see a pulsatile vessel here.
And the sluggish flow of the vein. No. So this patient's really interesting, isn't she, Shelley?
Yes, yes.
You're going to do a spectral trace. Yay.
It's so phasic that I'm just very tiny, very difficult to stay on, but there we've got our kind of more phasic flow rather than pulsatile. And I'm just going to come a little bit more medial just to see if we can just do a quick demonstration of an artery here. So here's the DAO up here. And we've got a big vessel here. And we've got other smaller vessels up in here. And I'm just going to put the pulse Doppler on. Okay, and that's...
So you got the power Doppler on now, Shelley?
I do, yeah. I did that by mistake, but that's okay.
No, that's okay. No, that's okay. I mean, power, it's good that you did that, because power is it's a great way to try and identify if there's a vessel in the field, because it doesn't rely on the direction of blood flow versus color Doppler. So that's the difference between color and power Doppler. And power is useful if you think that there is a vessel in the area that you want to inject. Now that is beautiful. Upside down, but beautiful.
We can change that.
There you go. There you go. So I am
Excellent.
down under, but you're just trying to make me feel at home.
Yeah, exactly.
Usually when we're looking at the facial vein, the facial vein lies anterior to the anterior border of the masseter, and the facial artery is more medial than the facial vein. Whereas in this patient, she's actually got an artery that's posterior to the facial vein. And again, patients
variability,
do not follow.
right?
Out goes the variability. Yes.
Excellent.
Yes.
Good. Well, I am just going to hand things over to Janesse for a few minutes, and keep the questions coming. We will answer them in just a couple of minutes. So Janesse, I'll hand it over to you.
Thank you, Dr. Roberts, for sharing best practices for avoiding complications for facial fillers and neurotoxin injections. And thank you, Shelley, for the fabulous live scanning showcasing our new voice controls and some of our new aesthetic presets as well. Just before we open up the floor to questions at the top of the hour here with our guest speaker, Dr. Roberts, we'd like to ask you a quick poll. We'd love to help everyone continue their journey in bringing ultrasound guidance to their aesthetic practice. So please do complete this poll if you'd like any additional information, and you can select as many options as apply. We have a global audience here today. Pricing and availability does vary by region, so please do feel free to request a quote and pricing. You may opt to speak to one of our experts about the advantages of wireless ultrasound. And if you'd like to discuss scanner features, please select that option. And you can also book a virtual one-on-one demo with our experts to see the new Claris HD3 in action. And we can send you more video tutorials with experts like Dr. Roberts and Dr. Stephen Weiner. Please go ahead and select as many options as you wish. While you complete the poll, I'll take a minute to introduce you to the Claris L20 HD3, the world's only ultra-high frequency ultrasound in a 20 megahertz handheld scanner. You no longer have to purchase a bulky system that's costly and complex to learn in order to improve patient safety and outcomes. Claris Ultrasound has changed the game in facial aesthetics. Miniaturization and innovations means high-definition imaging is now easy and affordable, with image quality that rivals traditional systems at a fraction of the cost, representing over 85% savings. And with the new Claris PowerFan HD3, you can keep your scanner cool with a limitless power supply, so you can scan as long as needed to treat complications if they do occur. I'd like to share a piece from a positioning statement on dermatology ultrasound by the European Federation of Societies for Ultrasound in Medicine and Biology. It states, a minimum transducer frequency of 15 megahertz should be used for dermatologic ultrasound. This means Claris is actually the world's only handheld ultrasound to meet and exceed this published guideline and recommendation. With best-in-class high-definition imaging of the skin, muscles, vessels, and fascia, you'll gain confidence in your needle placement, easily characterize and evaluate fillers, and more accurately treat complications, improving patient safety with consistent treatment outcomes. The secret lies in the technology, with 8 scanners featuring not 1 or 2, but 8 beamformers, 192 elements, and artificial intelligence that together deliver the crystal clear image quality only found in traditional systems, while replacing complex knobs and buttons, making ultrasound imaging fast and easy to use. Claris is also wireless, freeing up space with zero footprint. It's fully immersible and so much faster to clean and disinfect as well. Only Claris delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android devices with free updates. Available with our new membership, Claris Cloud allows you to easily capture and manage unlimited exams from anywhere. Your membership includes in-app Claris videos with experts like Dr. Roberts and Dr. Stephen Weiner, as well as onboarding with a Claris clinician to build up your ultrasound scanning skills. Claris Live delivers one-click telemedicine if you'd like to share live scanning with a colleague. Our new voice controls act as your AI-powered assistant with one hand on your needle and the other holding your L20 scanner. You can use your voice to add color mode, needle mode, increase gain, decrease depth, capture video, and so much more. Also included with your membership, the Advanced Aesthetics package includes AI-powered features to automate workflows like vessel depth AI, as well as the new aesthetic presets for the lip, temple, forehead, piriform, cheek, and chin to automatically optimize imaging. We'll now take 3 seconds to close out the poll. 2, 1. Thank you for participating. We will get back to you in the coming week. I'd now like to welcome back Dr. Roberts and Shelley for our live Q&A session. I hope you can join us as we've concluded the main part of our presentation for a lively Q&A session. Please use the questions icon in the menu bar now to ask your questions. And Shelley, if I can ask you to moderate, please.
For sure, yeah. We have quite a few questions, so we'll kind of plug away as best we can here. And like I said, we're going to go over the top of the hour here by a little bit, but I think it's important that we answer these questions for all you folks. The first one I'll ask is, do you ever inject the superior portion of the masseter under the zygoma? A TMJ dentist recommended my friend inject her upper masseter to alleviate residual pain she's experienced despite having her lower masseter contraction post-Botox. If so, how do you do this?
Okay, so I don't, but I'm not a dentist and I don't deal with temporomandibular joint dysfunction. So I'm going to defer that. Can you do it under ultrasound control? You can, but it's I don't deal with that. I'm predominantly injecting masseters for lower face reshaping, for grinding and clenching. And in that case, I'd probably refer on to a dentist. But, you know, if you understand and speak to the orofacial surgeons or the temporomandibular joint people and discuss it together, that might be useful because you can actually see it on ultrasound. But it's not something that I do.
Okay. What is your Botox reconstitution for this presentation?
In this presentation, my reconstitution was 2.5 mils of preserved saline.
Okay. Let me see. There's a lot of information, questions about price, and we will be following up with all of that information because it varies depending on the region that you live. Let's see, which filler injection points do you do under ultrasound guidance with needle imaging versus simple anatomy mapping prior to injection?
Yeah, so the areas that I now will always use ultrasound to inject under ultrasound control is the temple fossa. I'm scared of the anterior branch of the deep temporal artery. And even under ultrasound control, when I peruse the area with ultrasound, sometimes it's not visible, and sometimes you've got to use a few other techniques to actually showcase the vessels. But with ultrasound, I always look for the anterior branch of the deep temporal artery because it may have a link to the lacrimal artery and a potential site of blindness. I do identify the superficial temporal artery because it can connect with the supraorbital or supratrochlear. Again, another potential connection point for blindness. So, and I do look for the middle temporal vein between layer 5 and 7 within the temporal fossa. There has been episodes of PEs, but in the temporal fossa, if I'm doing the gunshot one up, one over, I'm too scared to do it, to be honest with you, without ultrasound, only because I use it and I keep finding a vessel in that vicinity. When I'm injecting with a cannula in level 3 or 4, I do peruse the area and then inject with cannula without the ultrasound, but I then place the probe back on. So the piriform recess is the other area because the angular artery is meant to only be supraperiosteal, apparently, in around about 1% of cases, but I found that they're in a higher frequency than that. So it's not that hard. Once you get into the habit of setting up the probe with the machine and your setup is right and it's easily accessible, trying to keep the area as clean as possible is also really important because we don't want to introduce another confounding factor when we're injecting fillers, which is trying to keep it as clean as possible so that we don't increase our risk of delayed onset nodules by introducing in any bugs at the time of infection. So if you're going to do ultrasound guided procedures, cleanliness is important. I probe cover. When I'm just scanning the area, I'll use a little condom that I'll find out because I saw in the Q&A, people want to know where to get it from and I don't know where, but I've got, I covered the probe. If I was concerned about sterility, there are sterile probe covers as well. So the answer is I inject temporal fossa and the piriform with ultrasound. The other areas, do I inject lips with ultrasound? No, I'll be there for 5 years. So I think ultrasound for the upper and lower lip is just there to showcase the anatomy for me or to go to deal with a potential vascular occlusion.
Great. Yeah, then my next question is going to be about the probe covers, but you answered that one. All right. For grinding beside masseter, do you block with neurotoxin other muscles? Grinding.
Yes.
Yeah.
Good question. The answer is yes, I do. Okay. Again, I assess the patient first, and whenever I have masseteric hypertrophy, it's a full history examination. You ask them whether the dentist has said that they're wearing down either their front or their back teeth. But I always look for temporalis hypertrophy as well. The four muscles of mastication of masseter, temporalis, medial and lateral pterygoid. I always keep my eye on temporalis. Do I inject it every time with neurotoxin? No, I don't. But if when the patient clenches and their masseters are large and temporalis is poking out, I do inject temporalis as well. And I do that just by direct injection with neurotoxin.
Okay. I think we'll have one more here. When imaging the piriform fossa, do you image in transverse or longitudinal plane?
Both. I basically come in and the first thing I do is I always look in B mode and I look in trans and then I turn into long. And, I use and then I put my color color Doppler on, and I'm scanning the area, I'm tilting my probe, I'm fanning it. Remember, sometimes, and I've seen this in a number of Insta posters, and they've got to be real because everything that we learn is on social media. But you know, when we're using a probe, it's a credit card slice. It's a slice thickness of your probe. You're only getting one section of the vessel that you're seeing. And we saw the tortuosity of the arteries in particular. In fact, veins in the face are quite unusual because they're straighter. And sometimes when you're seeing a tortuous vessel, it's the same vessel. It's just coming in and out of planes. So what I like to do is go into trance, especially in my higher risk areas, and put color on and go into long. And I basically fan and move in all directions until I can identify vessels. And if there's nothing there, I always get suspicious, because if I can't see it, I always blame myself and look at my settings. And I'll ask the patient to activate the muscle to increase the blood flow in that area so that I can see what's going on. Because typically what happens when you've injected a patient, immediately post-injection with your hyaluronic acids, because they've got lidocaine in them as well, you'll see this increased vascularity. And all of a sudden, these vessels that weren't there before you put the needle in, voila, they all rock up, and you're thinking, oh, wow. So is that because we've injected? Is it the lidocaine? So I always, I scan in long and in trans.
Yeah, and I same thing, like as a sonographer, you know, if we see something in one plane, we always confirm it in another plane. And it just kind of reaffirms that what you're seeing is real if you can see it in two different planes. So yeah, if it's possible, then that's what I would do as well. Yeah. Excellent. Well, all right. I think that brings us to the end here. Thank you so much, Dr. Roberts. That was fantastic. And thank you everyone for joining. And great.
Thank you for all your wonderful questions and for staying with us for the live Q&A session.
Yeah.
If we didn't get to your question, because there were many, we will follow up with you by email in the coming week. And a friendly reminder as well that you'll get a PDF copy of the slides and a recording of the webinar. We'll send you a link by email in the coming week, so do keep an eye on your inbox. And as we close out today's session, please do complete our closing survey to provide your feedback so that we can continue to bring you more educational sessions like today's. To conclude, I'd like to thank Dr. Roberts and Shelley Gunther for all of their insights, and a very big thank you to all of you for joining us from all corners of the world. Have a wonderful day or evening, and keep scanning. Thank you.